Hello, and thank you for joining the Forum on Children's Vision. I'm Dr. Stacy Lyons and a professor at the New England College of Optometry, where I serve as the chair of the Specialty and Advanced Care Department. I also serve as the chair of the National Center for Children's Vision and Eye Health. I'm a white female with curly brown hair and glasses, and I'm Zooming in my office today in Boston and so excited to be moderating this session. Before I introduce the panel, I'd like to emphasize the importance of this session, as Prevent Blindness has declared the year 2022 the year of children's vision. Prevent Blindness was founded in 1908 around the public policy mission to save sight in newborns. While the mission of Prevent Blindness has certainly expanded over time to embrace all eye conditions across the lifespan, children's vision remains the cornerstone of the work of the organization, as highlighted by the National Center for Children's Vision and Eye Health. We look forward to a future where all children have equitable access to the care they need to ensure all their eye care needs are met. The Year of Children's Vision focuses on the role that healthy vision plays in learning, health disparities, and access to care for underserved populations. And we're advocating for funding to support research and programs. Today's forum brings a variety of experts that together will demonstrate the vast landscape of children's vision and the needs that all sectors to play a role in creating a strong vision health system, from how children's vision data is important for telling the story of children's vision, to how the education system can play an important role in eye care. And finally, how to develop pediatric research life cycles that are more inclusive of children and families. We're especially excited to bring patient and parent perspectives to demonstrate the lived experiences of families, their challenges, resilience, and perspective. Now I'd like to introduce the panel. Sharona Washington-Lockett is a Prevent Blindness Aspect Patient Engagement Program graduate and a Prevent Blindness Texas Board member. Dr. Megan Collins is an Associate Professor of Ophthalmology at the Wilmer Eye Institute at Johns Hopkins School of Medicine. She is a co-director of the Johns Hopkins Consortium of School-Based Health Solution and serves as the vice chair for the National Center for Children's Vision and Eye Health at Prevent Blindness. Prisciliana Oleo is the Vision Care Services Coordinator at the Fort Worth Independent School District. Ms. Oleo works with Michael Steinert, who was unavailable last minute, so thank you for Pressy for joining us. Nicole Guyse is a Prevent Blindness Aspect Patient Engagement Program graduate and was the member of the Arizona Better Vision Together team. And Dr. Barbara Beyer is a professor of medicine and co-founder of the Multi-Regional Clinical Trials Center at Harvard Medical School and the Brigham and Women Hospital. We will have all the speakers present, followed about 30 minutes of questions and answers at the end of our session. You can submit questions through the Q&A button at the bottom of your screen, and we'll respond to as many questions as time allows. So let's get started and welcome Sharona Washington-Lockett to share your personal experience with vision loss.
Hi, my name is Sharona Washington-Lockett. I use she, her pronouns. I'm an African-American female in my early 30s with long curly hair, a round brown face, and I am sitting in my office with a purple flower Zoom background in extremely hot Houston, Texas. Today, we are all here to learn more about children's vision, vision health, and quality of life. I feel I can speak to each of these things from my own personal experience, and I'm honored that today I'll be sharing just a little bit of my story. In telling my story, I want you to think about how we can make things better for children with disabilities. But more than that, I want you to remember how it made you feel. Because having a strong feeling about something will always push you to change it. I was born with a congenital cataract in my right eye. A congenital cataract is a rare birth defect of the eye that can cause vision problems or blindness. A congenital cataract happens when the lens of the eye is cloudy instead of clear. So imagine looking through a world from a ball of smoke. 2 to 3 children out of every 10,000 babies will be given this diagnosis at birth. So to put that in perspective, about 10,000 babies are born in the United States each day, and at most, only 3 will be given this diagnosis. And that rare diagnosis is where my story begins. My parents had a huge decision when they went to the pediatrician for my first visit. They were informed I needed to go see a pediatric ophthalmologist. My parents had no idea what that even was, but they started their journey. And when they went to see a doctor, they told them that I had a congenital cataract. They saw a total of 7 doctors before one gave them any hope at all. The sentiment for all the other doctors was simple. I would lose my vision anyway, so there was no point of doing anything about it. But my parents refused to take that as an answer. And when they met the one doctor that gave them an opportunity, they took it. I had my first eye surgery at the age of 2 weeks. And at that point, we knew that there would be an uphill battle. We knew there'd be a lot of surgeries, but how many? No one could ever guess. What they could not have known or been prepared for was how I would be treated in a world where no one met anyone with my diagnosis and no one had a clue what my diagnosis was. You have to remember, this is before the internet, before social media, and before Zoom meetings such as this. Before you could just Google or ask Alexa, what's a congenital cataract? And since only 2 to 3 children out of 10,000 babies would ever even receive this diagnosis, the chance that I had met someone like me would be slim to none. This is when all you really had for community was your family. As you can see in my pictures, when I was extremely young, my disability was very seen. I wore eye patches, I was cross-eyed, my eyes were swollen, and it was very physically obvious that I had some sort of vision impairment. When my impairment was so obvious, it definitely came with its challenges. I would be teased, picked on, prodded, bullied, and pretty much just under a microscope. People were accustomed to seeing glasses and not patches. Nonetheless, it was nice to not have to explain that I had a disability since it was visually obvious. They may not have known what the details of my condition was, but they could see I had some sort of impairment. And in some cases, because they could see it, they attempted to be more kind. Once I started elementary school, I underwent cataract surgery and several strabismus surgeries. This is not only to improve my vision, but it improved the way I looked. And unless you looked very closely, you really didn't know I had a disability at all. Next slide, please. I fell into a world of unseen disabilities. In some ways, it was easier, and in others, it was not. I enjoyed not being pointed at and constantly feeling like I was under a microscope. I enjoyed not being asked, what's wrong with her eye? And I enjoy the privilege of seeming what the world perceived as normal. But it came with struggles, particularly at school. I would still have to defend myself and explain to teachers what a congenital cataract was, because many times teachers had no idea that cataracts could even be given or have in children. I still needed my parents to explain to teachers why I needed to sit at the front of the class when I looked completely normal. I still had to deal with ignorant teachers making ridiculous comments like, why don't you just put on glasses if you can't see? And my answer would always be the same: glasses don't work for me. And the worst part about it was going in and out of eye surgeries in the middle of the school year, because just like that, I was back in the same disability pool where everyone could see I had a vision impairment until my eye healed. And just like that, I was back in the unseen. And it would be a roller coaster ride of who would know and who wouldn't know. Ironically, when dealing with the seen versus an unseen disability, the pros and cons just cancel out. Things that were helpful when my disability seemed, when my disability was seen became challenging in times when it was unseen, and vice versa. even though for me, my condition was unchanged. The only place I felt I could be without questions asked was at home, a visit to the ophthalmologist, and interesting enough, playing sports. For my family and ophthalmologists, it was easy. I just had to update them. I didn't have to explain to them what my condition was. It was just dealing with anything new. And I enjoyed not having to think that no one here understood. And when I played sports, no one knew I had a disability. The doctors were actually very shocked that I played at all since I lacked depth perception. And when I asked my parents today, why didn't you tell any of my coaches that I had vision impairment problems? They simply say they never felt they needed to. I was just as good or better than all the other players. We're not really sure how, but somehow I was. And they felt that there was no need for something to be brought up that wasn't there. As a child, that is the best feeling to have no stereotypes and just to be a kid. I believe it's important to help children, especially those who have any disability, have a safe space where they don't have to explain themselves. Bluntly stated, all children, youth, and adults should feel a sense of safety, security, and well-being, no matter if everyone knows they have a disability or not, no matter if it's seen or unseen. It really doesn't matter. I have had over a dozen eye surgeries in my life. Just to name a few, I've had cataract surgery, several strabismus surgeries, a couple of corneal transplants, and a pupil reconstruction surgery. And with all of that, I still struggle with who should know and when do I tell them? Do I wait until I have another eye surgery? Or do I tell them outright? I am learning that there isn't really a right or wrong answer to this. It is truly up to the individual, the family, and their team of doctors to determine who knows, when they know, and how they should tell them. Going through my own journey of being in the seen and unseen disability pool has led me to talking to teachers and professionals regarding sensitivity training with vision issues in the classroom and in the workplace. This has also pushed me to help children learn to become better advocates for themselves so they can grow into being confident no matter what the challenges that may come their way. My story has made me a change agent when it comes to vision impairment and how healthcare providers, schools, and government need to walk away from the status quo and see things more clearly. Lastly, if you have any diagnosis, but certainly one that is rare like mine, that many do not understand or comprehend, remember this quote: "You will never influence the world by being just like it." Thank you.
Thank you. You're an incredible change maker. From sharing your story, I know that has just made me a better clinician. So thank you. Now, please welcome Dr. Megan Collins to present Leveraging Data Sources to Tell the Children's Vision Story.
Hello, let me just share my screen. It is so wonderful to be here with you today. I just wanted to publicly say, Sharona, that was an amazing and impressive talk. So thank you for sharing your experience. I'm Megan Collins, as Stacy Lyons just mentioned. I'm a Caucasian female. I have longer brown hair than in this picture at this point in time, and I wear glasses most of the time. Today, I'm working from my home office. These are disclosures that I have in terms of my my relationships outside of Johns Hopkins. So I'm going to take the next 15 to 20 minutes or so and talk a little bit about how do we leverage data to tell the children's vision story. And I'm so happy to be part of this panel, but I also realize this is a huge topic. So I thought I would start by sharing a little bit of my story and how I became, as a pediatric ophthalmologist, one to really appreciate the importance of collecting, disseminating, using, and lobbying for good data in pediatric eye care. So about 8 years ago, when I was recruited to Johns Hopkins, I had an opportunity to work with several of my colleagues at Wilmer Eye Institute and the Johns Hopkins School of Education on what was called the Baltimore Reading and Eye Disease Study. These are a couple of our students from the study, but the point of the study was to actually look at do kids who are in early elementary grades, they need glasses to see better? Are there some subset of kids who simply aren't learning to read because they can't see? And we went into 12 public schools across Baltimore, saw about 320 or so kids, and did vision and reading assessments at baseline, at 1 year, and at 2 year. And, the results came out of the study, of course, showing that for some children, giving them glasses helped them see better. But it also led me to have this sort of cavalcade of questions, because I saw so many kids when we went into the school setting that I hadn't seen in clinic before, that hadn't come to see an eye doctor in the community. And I wanted to know why they hadn't, how many hadn't, what kind of diseases they had, what types of policies were in place to help kids who needed access to eye care. And that really started some of our work thinking about what is the data in pediatric eye care. And these are some of the questions that I started asking. And by no means is this an exhaustive list of all of the questions one can ask about data in pediatric eye care. But some of the questions I had is, what do we know about pediatric eye care in the United States? What's the burden of eye disease? What are the burden of non-refractive conditions like Sharona is talking about, and congenital cataracts, or refractive conditions, kids who, like me, needed a pair of glasses from early in life? What's the difference in different age populations of children, whether they're preschool or school age? What have our professional societies in both optometry, ophthalmology, as well as pediatrics, internal medicine, what are they saying about vision care in kids, and who should be screened and who should see eye doctors? And what types of state or federal guidelines are there in this area, as well as what types of databases exist if we want to actually look into any of this data? And finally, this has become an area of great kind of personal interest for me, is school-based vision programs. And how do we think about these alternate strategies to deliver care to kids, and where are they, how many of them exist, and how do we optimize their impact? So when I started thinking about data, I started realizing that I had to change my mindset, which as a clinician was always thinking about individual health and thinking about one patient sitting in front of me in clinic and their health outcome, versus thinking about it at a broader population scale, and how what I may have been seeing with one patient in a classroom when we were doing the Baltimore Reading and Eye Disease study had implications for an entire population. There may be, thousands of children who weren't accessing care, and why weren't they accessing care, and what could we do about it? And so this sort of led to even more questions. I'm afraid I may leave you with more questions than answers by the end of this presentation, but some of the questions that we've started to dig into that I'll touch on briefly today is, how many states require vision screening? Specifically, my interest has been in school-age children. How many children don't pass vision screening, and how many children successfully or unsuccessfully don't connect with care? And that's a big deal, because particularly most kids who have a refractive eye condition, they're usually asymptomatic, and vision screenings end up being a big place of first entry of detecting children who are at risk. The second sort of big category of questions is, why do we care? Obviously, I care. I'm a pediatric ophthalmologist. I think eyes are really important, but how do we get everybody else to care? Why is it important? And what is the data that we know about the impact of vision, for example, on learning and an academic experience, as well as, for example, the impact of vision on a child's mental health, an area that certainly has drawn a lot of attention in the past several years due to the pandemic. Next, where do kids go for care? How many eye doctors do we have in the United States? How many pediatric eye doctors do we have? And what do insurance plans cover? And how does that differ if you have private insurance or public insurance or no insurance at all? And then, of course, an area that has become incredibly important, and I'm grateful that there's so much attention to it currently, is issues of inequities in healthcare and social determinants of health. And what do we know, or what do we need to know in these areas in terms of how it impacts access and utilization of care? And finally, in pediatric eye care, we don't work in a silo. It's important to learn from our colleagues in pediatrics, in endocrinology, and in school nursing. What other types of data are people collecting on pediatric health conditions? How do they collect it? And are there systems that they're using that might be important parallels for us? So I'm going to briefly touch a little bit on some of the data that we've collected, just to highlight some of the opportunities to collect data, but also some of the challenges that we're learning when we do collect the data. One, this is a project that we worked on with several of the members of the Prevent Blindness team and published about a year or so ago about what were the vision screening requirements in the United States for school-aged children as of 2021. And what you'll see from the map is that it is not every state has the same requirements. Not all states have vision screening requirements for school-aged children at all. And even amongst the states that do, they may vary drastically in terms of what assessments are included or what ages are included. Moving on to who fails vision screening, I can tell you our experience in Baltimore has been 1 in 3 children fail vision screening. So it's incredibly high. Now that is, I live in a high poverty urban city, so this is representative of that city itself, but it's important to start asking these questions and looking into the data about how many kids are failing. On this slide, one of the things that was significant to our team was that it was consistently high across all grades. And one of the things that I would hypothesize is if kids were getting access to eye care, they were failing a screening, or they were being referred, and then they successfully connected into the community, then the next year, presumably they wouldn't fail that vision screening again. And yet we were seeing year over year high failure rates. This, of course, brought a lot of our work in school-based vision care, which we've done a lot of research on, not only what is the impact of delivering care in schools on both vision, service delivery, as well as academic outcomes, but what are the challenges and how do you effectively leverage a system like this to improve access to care and build relationships with schools? And I'm very excited to hear from our colleagues at Fort Worth ISD, and Pressy's going to talk after me a little bit about some of the work that they're doing in school-based vision care in Fort Worth. So moving on to sort of why does vision matter? I think everybody here listening today understands how important vision is. And part of our charge is to make sure everybody else that we talk to and interact with understands that as well. And there are a lot of different ways to sort of split this or think about this. One is thinking about what types of eye problems exist. Again, what are the non-refractive eye problems, such as amblyopia, such as cataracts, such as glaucoma? What are the refractive error problems among kids who need glasses? But also, what are the implications of vision problems of any sorts for other indicators of child well-being? That could be mental health, that can be academic outcomes, that can be participation in sports, driving, employment later in life, and overall quality of life. And just to touch on a few things in that area, again, because this is an area of great interest to me, is there's an evolving body of data about the academic consequences of vision impairment and the role of some of these alternative programs of service delivery, which bring care directly into schools on improving children's vision, as well as improving their academic performance. And there's some work that's been done by our team, as well as a number of other teams across the US and now globally. Most recently, we published a paper in JAMA Ophthalmology this past September, talking about the impact of school-based vision care on academic performance in students in grades 3 through 7. And what we saw was really a profound, robust gain in English language arts, their reading assessment scores, particularly for a couple of different populations within the school, including females, students who were in special education, and students who were in the lowest quartile of their class at baseline, equating, this is some calculations from our education colleagues, to 2 to 4 months of learning time for all students who needed glasses, and 4 to 6 months of learning time for students who were in special education or in the lowest quartile. And the significance of that is, as we're thinking now as a country about sort of some of the negative impacts of COVID on school closures and learning loss and learning recovery, I think one of the things that I want to make sure is not lost in that discussion is the impact of child's vision on learning and the delays in some vision screening programs that have happened because of the pandemic, and that we make sure as we're moving forward that we keep vision as part of the equation to child's academic success. There is an evolving body of data now talking about the interrelatedness of mental health and vision problems as well. This is an article that came out this year in Ophthalmology, and it talks about, the interrelatedness again of ocular morbidity and mental health conditions, including depression and anxiety. This particular study talked about children who have vision difficulties having higher rates of depression and anxiety. And strabismus surgery for students for children who needed them have resulted in improved symptoms of depression and anxiety. So moving along, as there are many aspects of the data situation, the question is, who provides eye care in the United States? And how many pediatric optometrists and ophthalmologists are there in practice? It turns out this is a very hard question to answer. There are substantial geographic variations, and even when there are providers, or even I would argue a concentration of providers, doesn't mean that that equates to access for everybody who needs access. And there, again, are substantial variations based on insurance coverage, whether you have private or public insurance or any insurance at all. As a pediatric ophthalmologist, I've gotten very interested in the issues of growing the pediatric ophthalmology workforce. And this is an article now that came out, over a decade ago, 15 years ago at this point in time, which was starting to forecast shortages in the pediatric ophthalmology workforce. And I'd love during the Q&A maybe to ask Stacy about this, because I suspect similar things are happening within the pediatric optometry workforce. And this is a big problem, because as we were talking about the burden of disease and the number of students and children who need access to care, at the same time coming up against a limitation of providers nationally with geographic variation, it's something that we have to think about alternate strategies to ensure that kids get access and the necessary care. I mean, this to me was pretty striking that in APOS it stands for the Pediatric Ophthalmology Society. There are areas that there are 1.3 APOS members who are pediatric ophthalmologists per million persons. In other areas that there's more concentration, but that's a pretty substantial lack of providers there. This is new work that has come out from the group up at Mass Eye and Ear. And I'm just going to read the line from this article. There is a nationwide shortage of pediatric ophthalmologists, and that's something that I think we have to be planning for as we move forward. Social determinants of health is become an area of great attention, appropriately so. And one of the things that we need more data on is, how do social determinants of health impact pediatric eye care? This is a great figure from the CDC that talks about all of the aspects of social determinants of health and how they may impact health outcomes. Some data that's come out recently by one of my colleagues here at Johns Hopkins looked at data from the IRIS registry, which is a huge national registry of individuals who get vision care in the United States. And what they found is amblyopia, which is, again, one of the most common conditions that children are treated for in terms of pediatric eye care across the United States, and one that we have generally effective treatments for. They found massive discrepancies in the odds of successful treatment if you are African American, Hispanic, or Latino. And this is in 2022. So these are things that we need as a country and as providers to really be figuring out how to address. This becomes important for many reasons, including the interrelation of health and education. Students who have poor vision health, poor overall health will suffer more in terms of their education outcomes. And of course, students who have poor education outcomes, it impacts their health. So it's a compounding impact. And it's important to try to address early in childhood as much as we can. That, of course, was the impetus behind Vision for Baltimore, which is a school-based vision program that recognizes that we need to get care to kids early. And we do that in partnership with the schools and our other city partners who help make this program so successful. Looking outside of the eyeball or outside the world of pediatric eye care, there's a lot that I think that we can learn from our other pediatric colleagues. And that includes data in systems to collect data on immunizations, hearing, dental health, and asking such questions as to what data is being collected. What are the mandates for collecting data? That's a big one, because when things are required to be collected, they're more likely to be collected. And how is it being used to inform policy? One database that I've only recently become aware of that is pretty interesting, if anybody else wants to look into it, is the Cdc Hearing Database, which you can, just Google Cdc Hearing Database, and you'll see this huge database that they have annually of the number of kids who have been screened for hearing issues. And again, this is an early childhood intervention program, but still I think has implications in the vision realm. Finally, where are we going with all of this, and why is it important to leverage data to tell the patient's story? I think we need to continue to accumulate more data to inform best practice patterns for all of our patients and to ensure diverse representation of patient communities within our research, to advocate for equitable access to eye care, and to lobby across cities, states, nationally for standardized screening guidelines and data collection, so we can understand sort of where the gaps lie, and to continue to explore some of these alternate approaches, whether it's partnerships with schools or churches or libraries or pediatric providers, to ensure kids get access to the care they need. There are a lot of limitations and challenges when we think about data, but there's also a lot of opportunities. And I think many of these opportunities actually come post-COVID, as we've relied more on technology to connect with families and health providers. But some of the things we really need to think about is, what data do we want to collect? How do we collect it in a standardized format? How do we collect it in an electronic format? I can't tell you the number of projects I've been involved in that data only exists in a paper format, which brings a lot of challenges to synthesize and integrate. And how do we collect data in a systematic way and integrate with other data collection measures in order to sort of do paperwork burden reduction for the individuals who are doing this? I've included my contact information. I'd love to discuss this more during the Q&A today. I look forward to hearing from my colleagues on the rest of this panel, and I thank you for the opportunity today.
Thank you so much, Dr. Collins. And you were right. You're ending with more questions, because there's lots of questions that are piling in the Q&A, and we'll get to those in just a bit. I think it's really important. Your talk from so many perspectives, as you said at the end, from an evidence-based practice standpoint, from making decisions on how we use our precious resources that we have, and developing thoughtful and impactful policy. So thank you, Dr. Collins. And that was really excellent. Now I'd like to invite Presi Oleo to join me and have a discussion about the school factor, focusing on roles of education and eye health. And welcome and thank you for joining today.
Thank you, Stacy. Good afternoon. My name is Prisciliana Olayo. I am the Vision Care Services Coordinator in Fort Worth ISD in Texas. I am a Hispanic woman in my late 30s with brunette curly hair, some freckles. I'm wearing translucent tan glasses, and I am sitting in front of a white wall at my home in Fort Worth, Texas. Thank you for the opportunity to share our children's vision program in Fort Worth ISD. It's an opportunity to share how we have created structures that empower our families and our students to connect with eye care and how it can impact their academic achievement, a basic need for our students. So thank you for the opportunity.
Well, thank you for joining us today. So your school district has about 75,000 children in the school district. Can you share a little bit about what vision services are provided for the children in the Fort Worth, Texas independent schools?
In a partnership and joint effort with foundations, our Children's Vision Program provides professional eye care services to underserved children residing within Fort Worth ISD. Throughout the program, students in elementary and 7th grade are vision screened for acuity and eye conditions. Students who receive eye examinations and prescription glasses are identified as a result of the screenings. In addition, Fort Worth ISD and the Alcon Foundation have partnered to operate a school-based eye care center that will serve all children attending a Fort Worth ISD school.
So when you think about, educational professionals and medical professionals coming together, we don't always speak the same language. How were you able to get the school district administrators aware of vision and eye health needs for your students?
Understanding the opportunity we have in schools, particularly in an underinsured community, active and continuous engagement in the process of building structures, what we would call board champions, community champions, children's hospitals, higher education, county hospitals, the layering of cross-functional team approach. And for ISD's case, some of the teams that I can share with you is our student support services, school leadership, school principals, technology infrastructure, family communications, and facility and operations. Some of these departments may seem, or teams may be seen like, why include technology? Data collection is important to tell the story about our program and really to see how it impacts our academic achievement. Request contribution not only by a signed document. So what I mean by this is we have our leadership teams present during events, participation in board committees and decisions on internal areas of prioritization for services, really one-on-one relationship building with campus leaders, school nurses, families, and creating and committing to long-term goals for our program.
Can you give an example of one of those long-term goals?
Yeah, so one of our goals includes building family support systems, implementation of efficient and effective expansion of vision care services, from vision screenings to exams to eyeglasses, and then strengthen communication to increase vision care awareness for students, our parents, and our school nurses and administrators. And one that I think it's also important is develop data tracking systems.
What kind of tools do you use for that?
So an example, thinking of our implementation of effective and efficient expansion of vision care services when it comes to vision screenings. We have partnerships with different foundations or different hospitals within the city. And so the way that we align or we partner our different foundations or organizations is really based on the area where we're serving the students. So for example, if we have a partner who is their area of expertise is on lower grade levels or in preschool, we assign those partners to provide screening services to our pre-KK students. And then if we have other partners that have bigger capacity or their expertise covers the higher grade levels, then those would be assigned to those higher grade levels. As it relates to communication to our parents, we are developing, or we have developed communication that is in a simple language that is understandable for the parents to read. So for example, in different languages, and then also in a simplified language that it's not overwhelming bullet points where we tell them, this is how you care for your glasses, 1, 2, 3. And this is how you can connect with us to replace glasses. So simplify language, that it's not just language, but it's also the content is in a manner that they understand.
Thank you. What do you, when you reflect back, what has led to the success of implementing vision services in your district?
So Forward ISD can be identified as a real world example of how the collaboration of multiple stakeholders from different sectors of our community have come together to invest in future generations, our students, right? Stakeholders who share a collective vision, decided to contribute to a diverse community by addressing dire vision needs, form a partnership to build a children's vision program that serves students with a comprehensive eye health care system. So we have elementary school on-site services where we provide the vision screenings and comprehensive eye exams. We have our brick and mortar vision clinic that will support all grade levels with eye care services, prescription glasses and replacements. That is also important. Parent engagement, we building trust throughout school relationships and advocates, right? Our nurses and our school leadership teams, our principal champions are key. Community leaders as champions are also key, or churches, recreation centers, health clinics, and then really delivering on those promises to maintain their trust, to build their trust.
So it's really about the entire community, community-based solutions together. Yeah.
Absolutely, working together as a team with different stakeholders.
So I asked about, what are some lessons learned? What are some of the successes in this? What are some lessons learned for implementing vision care services?
Student needs are unique, and while a shared program goal is needed, program services and strategies must be tailored to the environment of the individual schools being served or the pyramid that it's being served, right? Different factors that we have to consider is racial, financial, and cultural. Understand that we may not be the top priority for the parent or for the student or even our teachers, but provide services from the program's purpose, right? An optometrist's goal is to ensure that they provide corrective vision for patients. So our purpose is to make sure that we provide the best vision care services, while we respect that that may not be the priority for the parent or the teacher, but still work collectively. Long-term goals and basic standards for the overall success of the program. Risks are always present, right? We had a pandemic, weather, different types of risk. Have a plan in place to anticipate effects and mitigate them. And importance of having positive relationships, again, not only with the community, but with everyone involved within our program.
When I think about individual children, and I know in my practice right now, I'm experiencing this as well. When you think about the challenges that you see that prevent your students in your school district from getting vision care or eyeglasses or any type of treatment, vision treatment, what kind of strategies have you incorporated to decrease some of these barriers?
Again, I'm going to go back to really understanding the different areas where our students live. So if I have a school that is high on a refugee population, where their recent immigrant arrivals to the country, their priority is really for them to understand the culture, to understand really how life is here, then my goal and my priority is to make sure that I take care of the vision care impact for their students. So I work in a way where I provide the services to the student, and then at the same time, in a respectful way, I integrate communication to the parents about the importance as to why we need to provide the vision care services for the students and how that impacts their academic achievement long term, how that's going to be better for them long term.
Thank you. I know your program is supported by a foundation. Can you tell me a little bit about this and why this partnership or these partnerships are so important?
Yes, so it's a public-private partnership. The Alcon Foundation, it's a local company, and a foundation with a commitment, to provide, to support local impact. We have increased their buy-in, and over the past 10 years, they develop and maintain relationships, invest time, volunteer hours, which is really more important than just the financial aspect. Increased support of research partnerships to access impact and support expansion and sustainability. So really receiving that support that is not just financial, but the investment of their time, their care for their students, for our students, has really made this partnership possible in Fort Worth ISD.
Thank you. Then, big picture, what role can the education system play in systems of eye care for school-age children?
I'm sorry, can you repeat the question again? My
Sure.
apologies.
What role can the education system play in systems of eye care for school-age children?
Really, we can impact the students and the families' long-term well-being for the students in a way that we work with different foundations and different departments within our school district for a really to better their life long-term.
And I know there are many people thinking, how do I get this in my area? So what actionable kinds of steps would you like to share for those who'd like to implement a similar program in their school system?
I think the most important thing to do is determine the needs and available capacity to meet those needs, establish systems based on the needs and capacity, and integrate stakeholders, right? Parents, the community, education, private organizations, foundations, healthcare, to work together, invite them to work together in a collaborative way. Establish the long-term goals with small actionable steps, right? And modify those steps or those strategies as necessary to where there's buy-in from all stakeholders. Consider student diversity. That is very important. And what I mean by diversity, we're looking at racial, financial, and cultural diversity when implementing the different strategies. And again, modified as necessary. Have your long-term goal established, but modify your strategies as you go along, and really learn and be open-minded and respectful of parents, while we try to educate them about the importance of eye care and how it impacts academic achievement and their personal life as well.
Well, thank you so much, Pressy. I truly appreciate the integration of the educational and vision professionals working together, so vision problems can be addressed early and students can reach their highest potential. And I think it's so important. So thank you so much for the work that you do. And thank you for joining us today.
Thank you. Thank you for the opportunity to be here and share our Vision Children's program from Fort Worth ISD. Thank you.
Thank you. Now I'd like to introduce Nicole Guyse to share her personal experience on navigating the health and school system for her daughter with vision impairment.
Thank you so much. And I just want to take the time to thank everyone for being here today and for listening to me and to my colleagues. I am Nicole Guyse. I am 37 and I am a Hispanic woman of very light complexion with long light hair. On screen will be a picture of our family on the next slide. And it is my husband, Brett, it's an older picture. So my husband is now 39 with a much fuller beard. Our daughter, Brooke, is our oldest, and she is now 11 and still in glasses. And Blake is our youngest, and he is now 6 and looks exactly like his dad, just minus the beard. Brooke, being our first child, was our trial and error baby. So most new parents are trying to figure out the parenting thing, and we were no different in that area. However, we were also trying to figure out some very basic necessities in our lives. As in my last trimester of pregnancy with Brooke, my husband was diagnosed with stage 3 melanoma and began treatment just a month before she was born. So we may have missed some very apparent signs that our daughter needed more care. It's hard to know, as hindsight is 20/20, as the saying goes. It would take us over 2 years before we would receive answers to questions we were desperately asking, such as, why wasn't our baby eating? Why did she keep receiving diagnosis after diagnosis with no explanation as to how or if they tied together? The answer would be a rare genetic condition called Cohen syndrome, and it would lead us to a devastating realization that our daughter was severely nearsighted, and her visual impairment went undiagnosed those over 2 years she was receiving care from multiple specialists. We have learned that often when a patient is being seen, the whole picture isn't taken into consideration. We have also experienced that often as a caregiver, you are in survival mode, which means you're constantly being hit with complex information and emotions to match while walking through emergency and chaotic situations. Bills are mounting, schedules are demanding, and you are trying to keep another human being alive while also dealing with day-to-day matters. And oftentimes this is all happening and you're unaware that you're on a more extensive journey. In fact, you keep looking to the light at the end of the tunnel because you believe that at some point this will end. And yet often it's only the beginning. Another common saying is, you don't know what you don't know. And we certainly found that to be true in our situation. It's why I think individuals, no matter the role they are in, should seek to be learners and educators. We are often in multiple roles at one time. I have found myself an advocate in need of an advocate on more than one occasion. We have been unaware of so many errors and injustices because we simply didn't know otherwise. And while that can be discouraging, every misfortune I have found to be an opportunity for me to learn empathy for the other individuals that will unfortunately find themselves in those same shoes. An opportunity for me to find a resource that must be out there. I just need to seek it out. An opportunity for me to learn and often teach others. An opportunity to be part of change. That's how I got to where I am today, talking with you, having a job I feel immensely blessed to fill at the school district both of our children attend, and partnerships with colleagues and relationships with individuals that fill my soul and better not only our daughter's care, but other families and individuals. When our daughter was in our state's early intervention program here in Arizona, the format changed, which resulted in her losing access to all of her therapies she was in need of: occupational therapy, physical therapy, feeding therapy, and access to other resources. I immediately went to Google and reached out to anyone and everyone that is associated with special needs, and I thankfully found Family Voices. They put me in contact with our state's parent training information center here in Arizona called Raising Special Kids. And they helped me with our immediate need, and later when our lives finally found some stability, they helped me get started on the journey of what I've heard others reference as being a professional parent. I volunteered as a listening ear to other parents and speaking to agencies that served families to offer a parent perspective. This would later give me an opportunity to connect with Eyes on Learning, which is Arizona's Coalition for Improving Children's Vision Health. It started with an email sent to volunteers with our state's Parent Training and Information Center looking for families whose children had a vision impairment and had difficulties receiving services. I had replied thanking them for asking, but let them know that that wasn't the case for us, as we, at that time, were receiving amazing coordination of care at the Foundation for Blind Children. They still asked if I'd be interested just in case, and I said sure, and I'm so grateful. I'm grateful that Raising Special Kids and Eyes on Learning took the time to feel me out instead of dismissing me, as that project I participated in, both Eyes on Learning and Raising Special Kids, became a huge turning point for me. I sort of faked it till I made it. I felt completely inadequate, so listened a lot to those in the room that had more education and experience than me. I spoke up every so often, feeling completely intimidated, but I knew speaking up gave me an opportunity to improve and or help me feel the room to determine if my presence was really of value or not. I will forever feel indebted to Karen Woodhouse, the learning director at Eyes on Learning, as she took the time to hear my concerns and help me grow into meaningful participation in that project. That project is how I got connected to Prevent Blindness, and my participation with Prevent Blindness has only furthered my development personally, professionally, and as a mom and advocate. And I leap at these opportunities for a variety of reasons. I admit it's an easy fit with my outgoing personality that loves to get engaged and with activities and meet new people. Each opportunity adds a resource to my Rolodex, equips me with information in my ever-growing toolbox, and prepares me for what is inevitably the unknown. And while I don't know if it's possible to eliminate the you don't know what you don't know, teaming up with organizations as a volunteer, as a peer, and as a colleague narrows the gap of the unknown and has shortened the time frame of accessing answers. As caregivers, often we are at the mercy of those providing services to direct us to helpful resources, whether it be for emotional, financial, mental, physical, or spiritual support. I have mentioned some ways caregivers can access those resources if they aren't guided to them, but the hope is that systems of care and those working in them will seek to improve how they can be a bridge and not an obstacle for families. This is no easy task as every family dynamic is different and presents with different needs and personalities. However, if those that are providing any type of care to families would educate themselves and seek to provide information in a helpful way to families, that would minimize missed opportunities. I recommend for caregivers and providers to have a separate email just for subscribing to organizations that relate to the area of need. So for us, that would be support for caregivers, navigating insurance, special education, our daughter-specific diagnosis. The inbox will be bombarded, but every so often you look through it and star the ones you want to tuck away for potential future need. Handing a caregiver papers with information or sending an email with attachments of resources isn't exactly helpful and at times can actually be harmful. It can unintentionally overwhelm a caregiver and stack on guilt as they feel they should make time to go through it, but just don't know how or have that time. Better to provide one resource at a time. In our state, our Parent Training and Information Center allows anyone, doesn't have to be a professional, to submit a referral with the caregiver's permission so that the burden doesn't lie on the family to reach out, but instead an organization reaches out to them, helps guide the family to other resources. This is the ideal that I believe all systems, medical, education, however they interact with the family, should strive for. I am immensely grateful for these resources as our daughter's medical care is ever changing. And advocacy for her within the school environment is a task that I have yet to feel accomplished with. But I am still learning, and I am learning how to better work with different personalities and how to help others see me as an equal and not just mama bear, and see our daughter's potential over her deficits. Our firstborn trial and error daughter is still teaching us this parenting thing, and she's reaping the benefits of all this, as one day she will have the opportunity to step up and take over. So I model as best as I am able the good, help her learn, and equip her for what's next and how to handle the unexpected. It's why I try to include her in discussions I have with those who provide services to her. I'm trying to lead our daughter in a lifelong journey, and I let the school and service providers know that I need their help. I come with questions ready to hear and ready to learn. It's almost comical, as the very thing I used to get in trouble with in my adolescent years is the very thing that has provided a way for me to develop respectful and professional relationships with those that work with our daughter, even when we disagree. It's the give me a logical reason and I'll shut up approach. Still working on the name, but you get the idea. I simply ask, please help me understand why we can't or why you must. And once I understand, I can either accept it or I can understand how it's difficult for you to achieve and work with you to help you get it accomplished. I think that's the key factor, helping those that serve our children understand we don't expect them to do as we demand. We desire them to work with us to help our children succeed. And that means we must be willing to be educated and willing to help them overcome the obstacles they face as well. While this is a very brief glimpse into our lives, I hope it helps highlight the importance of the professional-family relationship. I have learned that sometimes when I step out and step into something I'm absolutely unfamiliar with, I never sink. Sometimes I swim gracefully. Sometimes I get rescued with a floaty. Often I paddle along, figuring it out as I go along. This is how I've made friends with people I never imagined I would get to know, and how I became connected in areas I thought I would never have access to. How I have learned how to better local systems and advocate on larger platforms. This is how I have learned to work with others to make change. And this is how those that serve families and how families themselves can dive into this process of growth too. So thank you again for allowing me to share and for taking the time to hear from all of my colleagues today in more detail how this can be executed, no matter your role.
Thank you so much. Truly inspirational, Ms. Guyse. Thank you for sharing your story. You're an incredible advocate and role model. Last but not least, please welcome Dr. Barbara Beer to present on equitable engagement and practices for children's vision research.
Thank you so much, and thank you for the opportunity, and I really want to thank my colleagues for the wonderful perspectives they've given, and particularly, lastly, Nicole, for all the practical recommendations and spirited discussion, as well as Sharona, who opened this so brilliantly. I am Barbara Beer. I am a middle-aged, I guess, some would say elderly, white woman with shoulder-length brown hair sitting in a blue striped shirt in my kitchen, which doubles as my office. I'm going to speak to you today about, sort of diversity and inclusion in clinical research. And I do this from the standing of having founded and now run the Multi-Regional Clinical Trial Center, a research and policy center at Harvard Medical School and the Brigham and Women's Hospital that really works to improve the integrity, safety, and rigor of global clinical trials. And we do that work by engaging all stakeholders, parents, patient advocates and participants, academia, industry, nonprofit organizations, regulatory authorities, to think about emerging issues and not to stop at the definition of those issues, but really to then work to create and implement ethical, practical, and actionable solutions. Hoping that if everyone's around the table at the time we discuss how to move forward with a start to fixing a problem, that it will be acceptable to all and have a greater chance at life. And about 5 years ago, we started working on diversity and inclusion in clinical research and continue to do that, really thinking about how the analysis of group differences in outcomes among diverse populations has several advantages, including the fact that it can help identify underlying biological and socially relevant factors that affect health, but only if the data exists and only if one looks into that data to identify those differences. And that's really underscores Megan's call to better data and better analysis of that data. Diversity in enrollment seeks fairness in the distribution of direct and long-term benefits of research, and really all the talks you heard today would benefit from further research and research engagement. And the diverse representation in clinical trials is not simply a matter of biology, but also a matter of health equity and fairness. And I think participation helps build public trust in research and healthcare, and also makes the healthcare organizations more trustworthy by having to deal with the problems they see. But I want to emphasize that diversity is really multidimensional. It's race, ethnicity, it's sex, male, female, assigned at birth, gender, gender identity, gender expression, children, elderly, those at either end of the spectrum, the people with disabilities, LGBTQ, and many others, rural versus urban, educationally disadvantaged versus advantaged, economically different. So there are many different dimensions, and each person is represents many of those dimensions. You're not just one thing or another. And we think about this very much as a fingerprint, that you need to understand all of these dimensions to understand the person. But we need to focus on inclusion so that we can develop data that is inclusive and representative of the populations we serve. And that can only happen if each person is considered, and each dimension must be considered. Particularly true for children who have been underserved in clinical research for many, many years. If we look at the number, for instance, in the last, over the entire time of registration on clinicaltrials.gov, which maintains a registry of all clinical trials, all applicable clinical trials in the US and world, and just look at those from the time we started this database over a quarter of a century ago. There have only been 205 studies that list vision disorders in the United States and include children. 115 in the last 10 years, 71 in the last 5 years, and 16 studies with the keyword blindness. So we are understudying this incredibly important condition that impacts so much of people's lives. If you look at where those are conducted, you can see on the world map that most of them are in the US. There are some that are multi-regional. And if you look at how children come to be the focus of clinical research, it's often quite delayed. If you look, for instance, at COVID-19 cases in the past weekly, and look at the adult cases, of course, the surge in the beginning underrepresented the number of children that were afflicted, 2.6%. But by the time a year and a half later, where children were a majority or a significant minority of the cases, a quarter of new cases, and now about 14% of new cases, there still is an absence of research on children with COVID-19, so that we're late to the game. If we don't think about inclusion early, we are starting with 1 foot back rather than leaning in and being forward-looking. So it's underappreciated. The cases, for instance, are 20% of all children, and in COVID-19, and they deserve to be included in research. We need to protect children through research, not from research. And in fact, having data and having an appreciation of that inclusion and what that involves is going to change how we care for our patients and for our families. So we've been working on this for a long time, for the last 6 years, and looking at access to clinical trials and to accessible clinical trials, thinking about all the different ways that we can do a better job of achieving diversity, inclusion, and equity in clinical research. We came out with a sort of defense of DE&I about 2.5 years ago, having worked on it for many years. I don't suggest you download it. It's online, everything is there in our on the website. If you want a printed copy, get it at cost at Amazon.com. It's about 400 pages. But if we look at the children, you cannot develop data from children or about children unless they're included in research. And they cannot be included if we fail to ask them and include them from the get-go. Now, there are lots of barriers to inclusion at all levels, specifically from the sponsors worrying about the risks, institutions who would rather not take on the burden of research in children, since there are special protections for their regulators who are very cautious, investigators, referring physicians and staff, not only concerned about inclusion of children, but also the multidimensionality of children of different race ethnicities. Patient advocates and communities are appropriately concerned about whether or not they're being treated as guinea pigs, as it were, and then this challenge of data collection and analysis. But we do go through all of those barriers and attempt to find approaches and solutions to those, and really believe that with appropriate planning, this can be done. And we need to do that now in ways that have been different than what we have been doing previously, and make sure that we are inclusive from the planning stages of a clinical trial. So where does that start? That starts by patient and community engagement to support diverse representation, forming relationships with the communities. I see Prevent Blindness and this focus on eye health as one of those mechanisms to create a community in order to understand the needs of the communities, what's important to them, to provide training and support to community members so they can participate in the planning and execution of trials, and then to make sure that we're identifying shared goals of the research, tailoring the study design and conduct to be inclusive from the get-go. And of course, undergirding all of that is a need not only to look to trust from the community, but also to be trustworthy collaborators and research sites. And there are ways to do this throughout each of the pieces of clinical research, thinking through study question, study design, data collection, analysis, and dissemination of the research, and how to make sure that we're not only inclusive, but consider the needs of the community, whether that's a geographic community or a conditions-defined community, from the beginning to dissemination back to that community. So if you think about participating in any trial, it's a journey. The participants, either the child or their parent, has to have knowledge about the trial, first of their condition, then knowledge about the trial, access to that trial. They have to be eligible so that the eligibility criteria will fit them. That trial has to be accessible to the individual or their or decentralized in a way that makes it available to them. We really need to worry about trial burden and the operations and what we expect of people. We've had people travel down literally 2.5 hours from New Hampshire to Boston to, literally sit in a waiting room for 45 minutes for me to see them and say, your counts look fine, you're doing well. I could do that over the phone. Thinking about trial costs and accommodations, nobody should be worse off at the end of a trial where they've contributed to generalizable knowledge and be financially worse off at the end of the trial. And then thinking about the end of study and communications. And each of these components, thinking about the child, the parent or guardian, the caregiver, the siblings and family structure, or if necessary, the legally authorized representative, need to be thought about in each of these sort of moments in a clinical trial journey, because you'll find different reasons for people to have trouble contributing to research if you don't address those barriers and concerns upfront and provide research in a way that's accessible to not only the participant, but to the family. When we as an institution or researchers look at, the clinical trial, we look at benefit versus risk. Are the two arms in clinical equipoise? Do they look at the same? Is there a likelihood that after you've minimized the risk, there's an equal chance of benefit and that the science is important? But if you look at a family structure or you look at the participant's view, Yes, there's a benefit, but you also need to think about, childcare for the other members of the family, travel, lost work, the uncertainty of outcome, the discomfort, the challenges of finance, privacy risks, and a whole host of other, components that make it more difficult for people to participate than not. So how do we think about this? Underscoring what was said earlier, we think clear communication is really essential. We used to talk about people that have, poor literacy, low English proficiency, typical term. But we take the position that the listener doesn't have poor literacy. It's not the responsibility of the listener to make sense of the information, but it's the responsibility of the communicator to share information in a way that's understandable to the listener. And the listener's responsibility is really communicating that they don't understand something and being comfortable with saying they don't understand something. And as complex as health information is for someone who speaks English, it's an even greater problem for individuals whose preferred language is other than English. We've spent a lot of time on this question, trying to find ways of making sure that our communications are understandable, and now very much concerned with issues of translation and of inclusion of people whose first language is not English. Plain language is one part of health literacy, but it's not the only part. We need to think about how we present numbers, visualize the information, design our communications, think about culture and how people receive their information, what those interactive techniques are that will promote understanding. And before we put anything out, have usability testing by the people that are going to read and use that information. And there's a lot we can do over the clinical trial life cycle. It's not just the informed consent document. In the beginning, it's thinking about how we create awareness. What are our outreach methods? How do we include the community? How do we advertise or make known that trials are available? How do we inform the healthcare practitioners? Why is it the burden of the participant to find the trial instead of us reaching out to them? Thinking about flyers, recruitments, advertisements, and thinking, how do we access that population and make it known that we are available and wish to include them? How do we think about consent, instructions, calendars, so people come to their appointments on time? On study, medications, how do they report medication use, adverse events, satisfaction? And at the end of study, how do we communicate those study results, aggregate study results, and potentially individual study results to the participants? How do we transition from a clinical trial to care? How do we make sure that individuals have access to needed therapy if they don't have insurance? And how do we provide follow-up to them? This is an example of a injection guide that was lent to us by Merck, where we looked at this injection guide on the left and then helped them to translate this to a real health literate format on the right. And what you're seeing is a densely worded single sheet on the left and a much better spaced and available communication on the right. Everybody, I think, would prefer to have the communication on the right. So that's one example of the kind of conversion that can be done. When we think of numeracy, we have to be thoughtful about how we present it so that it is available for colorblind individuals, that we offer both the language as well as a visual description. And when we say things like, in 20% or 1 in 5 patients, tumors got at least 30% smaller, that itself nudges the participant to see the benefit. And isn't it a bit different if we also include in 80% or 4 in 5 patients, tumors did not get at least 30% smaller? Much fairer representation of the data. So thinking about how we present that is important. We've worked now on a plain language glossary because really we want people to use words in the same way across platforms. So, Merck should be using the same words as we use at the site, as the clinicians use in their care, and as nonprofit organizations use to describe it. And we have various, done this through patient advocates, taken a series of words, have a representation of that visually, as well as a number of other components to it. But if we think about promoting clinical research in children, as I said, the problem is global. It's this feeling that we shouldn't expose children, even if the condition involves children, to research, and instead of embracing research as a way of providing better care. If we don't have any data and give patients, children, medications or interventions that have never been tested, then everyone becomes an experiment, instead of having a way of analyzing things so that we are on the road to better care. We need a shift in perspective. We used to be very protective. I think there's a role for being protective, but also appropriately inclusive. I also think there are other challenges like global differences in the laws that different countries have available in healthcare that is the standard healthcare, in cultural differences and process differences. We won't solve everything, but I can say that it's no better externally than it is in the US. If you look worldwide at the number of studies registered, there are only 461 studies from the time we started collecting any data on visual disorders in research. This is visual disorders, not just blindness, the entire gamut, and just about 300 studies in the last 10 years. Imagine how many people are suffering from vision problems around the world, and how little we're doing to make sure that we promote better care and better data and better approaches to their resolution. So importantly, we need to figure out not just how to listen to the community, but how to listen to children and how to listen to their parents. And I think that we're seeing in America and elsewhere a real promotion of the patient voice in research, and having patients closer to the table, if not at the table. I think the same is true for children. We need to figure out how we can do that well, and and include children in actually the thinking about research and what their opinion is and how they do that, and make sure we understand and explain it to children. So how do you know if you've spoken to enough children? If you speak to people at the Children's Hospital of Boston, is that typical? Do we need to worry about representativeness? Can one child speak for another, and can anyone speak for everyone? So, and even thinking about a difference between a 7-year-old and a 17-year-old is a huge difference in understanding and sort of engagement. So we've started to work on that and thinking about creating resources for children directly, or young people directly, to be involved. There's a gap in general information about clinical research. So we've started to try to address that. All materials were developed by young people and reviewed by young people's advisory boards, international stakeholders, and we're developing basically a library of resources, which we call For Kids. This got started partly in COVID-19, when people couldn't even access person-to-person contact for the kids. And we started to develop these general research explanations, because frankly, it was independent of the study itself, but people should be able to approach a study with an understanding of what they're being asked, why they're being asked, and what their choices are in being asked. Can they decide not to join? And what questions can they ask of the researchers? We've developed some studies for some resources for younger children, a comic book that explains medical research, and more recently, a comic book about contributing tissue and data to biobanks, and now actually have created that into a YouTube video, which is a voiceover, so it's not a reading project. So we're all accountable for doing this better. We're in a current state, and we need to sort of address what we can to be inclusive, and inclusion will lead to at least an appreciation of those things which contribute to inequities in healthcare, with the hope of providing routes to change. And I think all of us are accountable in different ways for making sure that this looks differently. So, we need your help. We want to know how to do the work and do it well. What does it mean to see representativeness, or to make sure that we're adequately representative? We need to share information as we learn successful strategies, and look forward to working together. And it's been an honor to participate today, and look forward to the discussion together. Thank you.
Thank you so much, Dr. Beer. Protecting children through research, not from research. I love that quote. It really is a perfect statement with your topic and with research in general. Closing this research gap will certainly give us a better scientific understanding that will impact health and would have to drive health equity. So it just thank you. Thank you for your presentation. I'd like to invite all the presenters back for our question and answer session. So if everyone could come on back, and thank you. And I'd like to start with a question for Ms. Washington-Lockett and Ms. Guyse. Thank you for sharing your story. Question came up: how do we teach children to be advocates for themselves?
I think it's a three-pronged approach. So I think first they have to know what their diagnosis is. You cannot be scared to inform your child what the diagnosis is. They really need to understand it as much as a child can. Secondly, I think they have to feel free to speak about it in all places. It doesn't matter where they are, they should be able to talk about their diagnosis. And lastly, it's a mindset. They have to be confident, they have to be resilient. And I really feel like, even just from my personal story, children that have any sort of diagnosis have to grow up a little faster. They have to be a little bit more mature. They have to just kind of get with it, because people are going to question them. And you just have to really pour into them that they got this. So it's really a mindset to me. That's my three-pronged approach.
Yeah, and I would agree with Sharona there. And I would just say it's a common phrase used in the disability community, but it's a good one. And it's the dignity of risk. We give the dignity of risk to our son, who does not have the same syndrome as our daughter. When he turns 18, he could move out, make awful decisions, and that's his choice. But when children with disabilities, when they reach of age, oftentimes they're sheltered and protected. And I get that as a parent fully, but that's just not the reality. And the more that we hinder that growth, we're hindering it emotionally, we're hindering them physically, we're hindering them mentally. So we need to give all of our children, no matter their abilities, disabilities, the dignity of risk. And the more we do that when they're younger and they're in an environment that is nurturing, that is supportive, that is safe, then the more they can make those decisions in hopefully a wise way as they continue to grow up. And then they will be able to advocate for themselves because they've been given that self-assurance, they've been given the tools, and they've been given a chance to figure out discernment on their own. So dignity of risk is really what I would encourage for all people, so that children can advocate for themselves.
Thank you. Dr. Collins, can you give an example of how the data needs you described related back to the vision story for a child? Are there any examples that come to mind?
Sure. That's a great question. So, and I think she might still be on here. Josephine Away, who's a pediatric optometrist with us at Hopkins for a while and is now in Kentucky. But when we did the Baltimore Reading and Eye Disease study and we would go into the schools, we would actually be the ones doing the exams. And it was really when, doing an exam is very different than looking at a whole bunch of data about a kid and seeing what's happened. And you got to talk to the patients and sort of learn their stories and see when they had glasses that were duct taped together and see the difference for them when they put on a pair of glasses at times. And I think those personal experiences of seeing kids and then talking to their families and learning some of the challenges navigating the system, I think, the perspectives that Nicole and Sharona have shared, as well as Barbara, in terms of sort of how do we send material home to people in a way that is accessible and understandable, they all kind of resonate so much, because I think if we're trying to advocate better for our patients and their families and have them help advocate better for themselves, it's having a common language and sort of understanding of what's going on. And developing that as the foundation. So there's lots of stories like that where I saw kids talk to them and talk to their parents and just learning sort of what their journey was, and maybe if they didn't get care, why they didn't get care. And it was always a lot more complicated than I would have assumed. And I think that's where you have to check your assumptions at the door, and you really have to actively listen and really sort of create that opportunity to learn from your patients.
Thank you. Would adding eye health instruction added to school health curriculum help with student identification and preventative vision care?
Who's this one?
Pressy, I'm going to give that to you.
To me, Stacy?
Yep. So do you think adding eye health instruction to school health curriculum would be beneficial?
Yes. Going back to the different information received from everyone in the team, the more that you communicate from the different areas, from the different branches, the more impact that you can make. So I say yes, adding that information, in different languages, coming from different areas, as much as you can, you're providing that same message, in multiple times. So yes, I would say that it would add to that goal that, education for the parents to where we can make that impact is key. So absolutely.
Nicole, as a parent, would you agree?
Absolutely. I don't think I can really add anything to what was said, because I think it was stated perfectly.
Nicole, while I have you on, there's been a lot of questions in raising disabled children and nurturing in safe environments. How do you prepare them for the meanness and toughness that exists in a world as a disabled child? Unfortunately, maybe targets, because they are different. And Nicole, and then Sharona, if you want to jump in, that would be awesome.
Yeah, that's a really great question. And I almost didn't wear mascara just in case this was asked. So unfortunately, it's a reality that I think all of us face. We face it in the childhood playgrounds, and we face them as adults, right? Our daughter was no different. In second grade, she experienced discrimination from an adult that was actually in a position that was supposed to be helping her. And it was I feel like the best word is traumatic. It was very traumatic for me as a mom to engage with this adult and find out that they had been discriminating against our daughter for an extended period of time that I was unaware of. It gave me an opportunity, though. Our daughter is extremely bright. She communicates primarily with a communication device. So communication is challenging with us. And it gave me an opportunity to pull her aside and say, Brooke, God has made you amazing. And you are beautiful and you are bright and you have so much to offer. Not everyone is going to see that. And sometimes they are only going to see your disabilities. And if you allow them, because it means it's easier for you, I don't have to do homework, I don't have to do that task, somebody else will do it for me, then you're not letting them see who you are, and you're allowing them to hurt you and mistreat you. And that's going to keep you from getting to do things that you want to do, that you should have the opportunity to do. And it's hard because our daughter is so happy-go-lucky and she smiles a lot, but we get glimpses a lot that we say things and later on it registers. And it goes back to that dignity of risk. I gave her that opportunity to have a discussion with her, and she could dismiss it or she could act on it. And we continue to have those discussions with her. And I would encourage, there's a lot of really great books out there for kids who have disabilities and for kids who don't have disabilities for how to engage with them. And I would encourage all adults, whether you're a parent or not, to encourage kids to look into those things so that they know that it's not uncommon, but it's also not right.
Can I follow on with a question? Do you, as a parent, routinely, if not confront, but discuss the issue with whoever's the perpetrator? And how do you do that when they're kids?
So if the perpetrator is a kid discriminating against, yes.
Yeah.
So with kids, it's so much easier because I understand that they don't know any better, right? They're either responding because this is the first time they've encountered someone like our daughter, or this has been discussed in their home and they don't realize that that's wrong. And so, and that's really what happened with this adult, right? This adult had never encountered a student like our daughter and had grown up to be that way. And so I just talked to those kids and I found a 50-50 approach. Some kids throw attitude back and some kids are really receptive. Either way, after I've had a short kind of heart-to-heart, like, hey, she's actually not stupid. She just learns differently. Just like there's things that I know that you don't know and you're not stupid. You just learn differently. But then when that child's gone, I go back to our daughter and I always make sure that I have that discussion back with our daughter. Our son actually unknowingly was he was making fun of our daughter, not realizing it when she was stemming. And when I explained to him what was happening and how that might be perceived by her or by others, he was in tears and I would never make fun of my sissy. So he just had no idea that what he was doing was hurting her. So again, it's giving all kids the dignity of risk and having that discussion and allowing them to respond.
Thank you.
Sharona, did you want to add anything?
Sure, totally different perspective, probably, since I was the kid who was being teased. But I'll give you a story. I first want to say that you can't get around it. As a child and as a parent, you gotta accept that it's gonna happen. It's gonna happen if your kid's completely normal. It's most definitely gonna happen if your kid's a little different. That's the first thing I think is acceptance. But I was in 5th grade at the time and I had an eye surgery. I think this was my pupil reconstruction surgery. So I had to wear a big old patch. And at the time I had some complications and my eye was like leaking. And I was very concerned. I did not want to go to school. No one knew I had an eye issue. You have to remember that. So at this point, I've kind of kept it on the wraps. No one really knows. but I was bullied very badly. I would have pictures where kids would draw pictures of a girl with curly hair and her eye patch and blood coming down her eye and eyes popping out. This is the kind of stuff I was dealing with walking into class every day. And it was rough. You know, what I remember doing first was informing the teacher, because that's kind of what they tell you to do initially. But the teacher really was not well equipped to even know what to do. And I think that's another thing. You're hopeful that the teachers will step in on your children's behalf, but sometimes they don't even know how to handle this situation. They've never even dealt with anything like this. This is not just someone being picked on. I'm being pretty much taunted at this point. So what I can say and what I'm very fortunate about is that I did have my parents who were huge advocates for me. They came into the school, they spoke to the teacher, they explained to the nurse, and we got to talk to all the students. Since it wasn't a one-time thing, it had to be at least 20 students sending me these documents. So it had to be a whole class discussion. I think the best way you can really handle it is just be ready for anything. You have to be very flexible, and you have to be understanding that kids are kids, and they don't know any better. And it's like a groupthink effect. One kid does something ridiculous and then everyone thinks it's cool. So as an adult, I still struggle with these moments. And I think that's the biggest thing that you have to teach your child. How do you get over being bullied, and how do you deal with it in the future? And that really only comes from perseverance and really just teaching them that it's okay to be different. All those quotes I keep saying to myself, tell those quotes to your kids. It's beautiful to be different. You can't be, you have to be different to be irreplaceable. These things, it's just really important to just keep mentoring to them. So that's my best advice I can give. Just continue to pour that into your children. You can't get away from them being bullied, but you can figure out how they can handle it in the future.
Thank you. Thank you so much. I'm going to switch topics a little and Barbara, and then I'll pass it over to Megan after. How do parents and guardians find out about clinical trials that might be good for their children? And then the second part of that question is, how do you address the concerns and fears that parents may have in enrolling their children in clinical trials? How do you address that as parents' reservations?
Thank you. So access to clinical trials, just finding out the information about them is challenging, and there is no good resource for it. We hope that over time, the National Library of Medicine will do a better job of making their resources patient and parent friendly. I think there's a huge role for nonprofit associations, parent advocacy groups, and also, the condition-specific advocacy foundations to do that, because really what happens, I think, in practice is patients or families Google now that we have Google to find out where the supports are, and if the supporting organization knows about what's available, then it's much easier to connect that dot. It's indirect and it's not ideal, but I think that we're working towards better solutions. I also think that the challenge of having trials largely based in academic medical centers is a problem, and that we need to address that in the communities we serve. How do we address parent or child concerns about, quote, being a guinea pig, or, what are the risks? I think by being honest and clear and explaining to people what we know and what we don't know. And making sure that they understand that there are controls in place for monitoring the trial. It's not that you get into a trial and you have to stay in. You get in and then you're monitored, and you also have agency and choice as you're going through it. I often say to oncology patients, you should try this. If it doesn't work for you, no loss. We step away from it. But if you never try it, you're just letting your disease, progress. So I think being honest and having a good relationship with individuals is really the core of, of the answer to that question. People used to say you have 2 ears and 1 mouth, use them in that order. Listen and appreciate that everybody's concerns are a bit different. And we don't have a ready answer for everything, but by knowing those concerns, we can do our best to address them. Megan?
I think Barbara's covered it so well. I think the two things, as a pediatric ophthalmologist, I get questions all the time. I get optic nerve hypoplasia patients and oculocutaneous albinism patients, and they're always asking about trials. Patient advocacy groups are really powerful in this realm, in that a lot of times they have resources and information that they can direct parents to, but I don't think every single disease has that. We see a lot in pediatric glaucoma and pediatric cataract. We don't see as much in some of the more rare conditions. And just to echo what Barbara says, a lot of times if a child has a rare condition and is being seen in the community, it may be the only time that doctor or anybody in that practice has ever seen that. So sometimes that can be even more isolating for parents, because they feel really alone, because they, even their healthcare providers may not feel really familiar with the condition that they have. As much as we can sort of use and build accessible resources for people, I think that we should. I think a lot of, if you're savvy, there's a lot of information you can find out. You can go to clinicaltrials.gov and find every single clinical trial going on that's registered in the United States, but that's not something that is accessible to most parents, or they even understand some of the words that might be associated with a clinical trial. So even creating some type of primer or small video for parents as, if you have a child with a condition and you're interested in clinical trials, here are some of the questions to ask, here are some of the places to go for information, might be a start. I'd sent a message to Barbara in the chat. So I've sat on the institutional review board at Hopkins for years now. And I don't know any of the parents here, if you've ever had a child in a clinical trial, sometimes you get a 30-page document, and it is the consent form, and is your permission form to participate. And sometimes people and our providers on here may have had the experience of having to read these or go through these with a patient. And sometimes I've seen people just give it to a patient and walk out of the room and say, if you have any questions, let me know. And that's not the way to do it. You have to take the time, you have to have the dialogue, you have to listen, you have to do not just do you have any questions, but actually assess people's knowledge and understanding of what they are participating in. And the same as with clinical care, it's not a one and done. You have an ongoing relationship and an ongoing responsibility to your patients and your families. So if you feel like you haven't covered everything in one visit and you need to see them again, or you need to bring it up on the next visit, you do. And I find that parents appreciate that, because sometimes it takes a while for things to sink in. Sometimes I've given a diagnosis that I expect a parent would probably be upset about, and their reaction doesn't match. And I honestly think it's just pure shock that they get something that is not what they were thinking about. And then a lot of times there's an entire process sort of blaming yourself. And what did I do that caused this to happen? And it's really important as a provider, whether you're talking in a clinical or research aspect, to just sit with your patient and the family through that. You have to be part of that dynamic. That is a really hard thing for a family member to go through. And you've got to be their advocate and partner through that.
Thank you. I'm going to switch gears just a little. And in Megan's presentation, she mentioned that it was about 30% of children failed vision screening. Pressy, in your school district, about what percentage is the failure rate from vision screening?
Hi, let me look at my data here. So in our, and I'm going to focus specifically pre-K through 5th grade. That's because that's where we have most of our data collection. We have about 20% failure rate for students in grades pre-K through 5th. So just to give you perspective on that number, we vision screen about 35,000 students this past school year in grades pre-K through 5th. And out of those 35,000 students, we had a 20% failure rate. So that's about 7,000 students that failed their vision screening.
And then the follow-up question, from those children that failed the vision screening, how many accessed care?
So, and again, I'm speaking with my pre-K through 5th. Out of those students, we had about 47% of our students received a follow-up care or a comprehensive vision exam out of those students. So we still have 53 students or 53% of our students who did not. And that is just pre-K through 5th grade.
Thank you. What software do you use to conduct vision screenings in schools?
So to collect or to document the vision screening results, we use Swift Screen. It's and we started using this application in the fall of 2021. And basically what we do is this application is mobile. So you use this with an iPad or even with an iPhone, where you go in into any type of setting. So for example, we are conducting vision screenings in a classroom setting type of style. You take your device, your iPad or your iPhone, and you immediately are able to enter the acuity results for the student. So that has been successful for our students and really has helped us be able to manage our reports and our massive uploads into our student system and even for state reporting systems. So that's what we're using in Fort Worth ISD, Swift Screen.
Thank you. Nicole, you mentioned a few organizations, and it seems like some of our participants have already been Googling some of those organizations. What advice would you give for a caregiver who finds themselves in a similar situation as you?
That's a great question, and it's challenging because every state and every community and every family dynamic is different. And so I would say, one, give yourself grace. You feel like sometimes people feel like they got to hit the ground running, and that's fine. But also, as Dr. Collins mentioned, you're still trying to process a world you weren't anticipating. So you're always going to have to navigate. If you need to give yourself some time, you're not going to lose ground. And then I would say, reach out to those you do know, understanding, taking information with a grain of salt. And then reach out to those you don't know. So every state has it's called a PTI, a Parent Training and Information Center. And every state helps families navigate special education. However, some of those PTI centers will help families navigate all systems of care. And so I recommend start there and ask them what they will help you with. And you'll find out, and if they only help with special education, and let's say that's not an area that you're asking about, then ask them, well, who can I go to? And it's really the squeaky wheel gets the grease. And so sometimes it's just saying, if you just answer me, I will go away. And asking those who are seeing your kids, who do you recommend I go to? Because there's so much out there. It's just finding out where that is. And I wish it was more accessible. I wish it was more consistent. Until it gets to that point, I would just say, reach out to who you do know, reach out to those PTI centers, and then give yourself grace. If you find an organization later on down the road and you're like, I wish I would have had them earlier, you were doing other things earlier. So give yourself credit for that.
Sharona and Nicole, you both are graduates of the Aspect program. Can you tell a little bit about your experience in that program and what motivated you to do that program?
And maybe start with a little bit about what that program is.
Thank you.
So that program is a program for caregivers, physicians, residents, patients. It kind of just teaches you how to be better advocates for the patient. I definitely, at the time, I was a residency program coordinator, and I wanted all my residents to go to this because I was in the Department of Ophthalmology at UT. And I thought every physician, optometrist, ophthalmologist, caregiver should go. If you have a moment, sign up. Okay, just throwing that out there. So I went ahead and joined because I'm in the board of Prevent Blindness in Texas, and the CEO actually is who brought it up to me. I had no idea about any of this. So I signed up, and it was one of the best experiences I've ever had. I got to hear different perspectives from other patients. Like I've said a few times before, I never really had a sense of community in the ophthalmology world. Kids today are having things I never could have imagined when I first was diagnosed with this. So the fact that this is here and it's available for use, please, log in, join. The community is amazing. And I just think it's a lot to learn. They tell you about different clinical trials. We learn how we can tell our stories, and it's just really a beautiful forum. So I'd really push for anybody who knows a loved one or who takes care of people, or if your career is anywhere dealing with the eyes, please join.
Yeah, I couldn't agree more, Sharona. And I would just say, so I found out about it through Arizona's Coalition for Improving Children's Vision Health, which is Eyes on Learning. And I was so grateful because I had been blessed to participate in another advocacy training. This was specific to vision, and it really changed how I navigate our daughter's vision health. Not only her medical condition, but her emotional health, because like Sharona said, there are patients on there, self-advocates. And because our daughter's communication challenges are complex, having a back and forth discussion with her is difficult. And so getting to hear from other patients of what she might be going through, depression and mental health and those kinds of things that weren't really on my radar, really helped me a lot. And it gave me an opportunity also to advocate. There's a really great, it's called Eyes on Capitol Hill, and we got to speak with legislators about why funding is important and how this impacts not only individuals and families, but society as a whole. And the Aspect program gave us that opportunity, and didn't just give us that opportunity, they equipped us for that opportunity. And from all of that I've gleaned and learned, I've been able to apply in other areas of my advocacy. And this is a kind of a great answer to Dr. Lyons, you had asked earlier about getting children to advocate for themselves. It's programs like this. There are other programs out there, and I would encourage to do a Google search, but definitely the Aspect program. Look into that for individuals who have a vision impairment or who are blind themselves. This is a really great way. I'm going to be sharing Sharona's presentation with our daughter so she can see how self-advocacy is empowering.
Can I just add that around the country and internationally, there are a number of different young people's advocacy groups, YPAG, and probably for slightly older children, but starting earlier and earlier, that creates that sense of community and also helps train them to be good advocates for the community. ICANN is one in the US that really has different youth groups around the country. And it's really helpful to know that there's company out there. So.
Well, thank you so much, everybody. And I'd like to thank the presenters today. I appreciate all of the work that is being done, but we still have so much more to do in order for all children to have healthy vision.